Hi, everyone. I'm Lisa Bowden, the product marketing lead for utilization management here at Availity. And joining me today is Lydia Turner, senior strategy consultant at PwC. We've invited Lydia to join us today to take a deeper dive into some of the topics we introduced in our Reclaiming Utilization Management webinar. Lydia, thank you so much for being here with us today.
Yeah, thanks for having me. Great to be back to talk about this topic some more.
Great. Let's just kick it off. One of the first points you made in our webinar was how the regulatory and market forces are driving so much change in UM. You talked about how organizations are demanding more from UM operations while asking for it to be done cheaper. There's constant administrative pressure to perform more efficiently, especially when it comes to insourcing. In particular, you recommended two things to help health plans manage those pressures: a solid understanding of their own performance or current state, so to speak, and direct control over their operation so that they can quickly adapt to those changes. So, can you take a minute and tell us a little bit, in your experience, how you're helping health plans get a better understanding of their current state and their current performance?
Yeah, Lisa, it's a great question, and I'm really glad we're talking about how to get better insight into their performance, right? Health plans have so much data, so it's really not a question of collecting more of it. This really starts with using the data that they have and turning that data into insights that can drive to change, right? So When when the data, like we said, health plans have a ton of data, but it's often fragmented, hard to access, or really just not leveraged or analyzed in a way that drives decision making. So what we try and do is focus on integrating all those different types of data, which can include workforce performance, how your actual teams are moving work through, compliance data. How are we doing on hitting some of those minimum thresholds? Financial performance across codes and different services and different areas of the practice. Clinical data to see how our members are actually trending. I bet UM is intended to manage utilization of services and drive folks to get the care that they need in the setting that's appropriate. So bringing all of those data points together can create a single coherent story about how we're actually managing utilization, right? That's what UM is really intended to do. So when those data sets all come together and they are reviewed and timely, that's another important part about this. Leaders can clearly see where processes are breaking down and where improvements will have the most impact. So it's about having that holistic view of your operation across multiple domains and therefore getting actionable insights from that information. It's not about necessarily more data. It's using the data you have to drive insights and guide where transformation needs to happen. That's why investment in medical economics and analytics capabilities is critical and something that we often talk about. These functions need to be embedded or at least leveraged better by our UM operations so that they can get those timely insights and use data from across the organization to inform how they can better leverage their utilization management function.
Awesome. That makes good sense. Let's talk a little bit about how that works in insourcing versus outsourcing or a delegated model. In a delegated model, like how a health plan can, once they begin to gather that data, how can they leverage that to get the control they need? And how can insourcing or a hybrid model support that versus some of the challenges they might face in a delegated model?
Yeah, another this is the other side of that coin, right? Is really insourcing and or really even a thoughtfully designed hybrid model gives payers that direct control over the levers that matter most: policy interpretation, clinical decision making, and operational tuning. So when teams work more closely together, leaders can adjust that criteria, the routing, the review thresholds quickly based on real-time performance and regulatory feedback. Again, because they have that information all right in front of them. As we talked about before, they're bringing the data together to get those insights, but it's available for them. So, in a hybrid model, it's a little bit trickier. But again, the key is maintaining ownership over the policy analytics and governance internally while using your external or your delegated vendor, however, whatever you want to call them, to really just to support scale, right? So that structure allows payers to still adapt faster, protect quality, and respond to market and regulatory changes without having to wait for vendor driven change cycles. You're still in control, but you're using that vendor for either capacity or specialization or something like that. Ultimately, control is what enables the agility, and agility is what allows payers to continuously improve without introducing unnecessary risk.
Got it. All right, let's talk brass tacks for a minute, like real tactical. Let's say a health plan is finally getting to the point where they're ready to pull the data together and roll out some dashboards, right? Let's talk about prioritizations. We may not get all of our metrics the first day, but we're going to start with the foundational ones. So, Lydia, tell us in your experience, what are the best, most foundational key metrics to start with in a scaled plan like that? What are the key OKRs to do it better, faster, and cheaper? If someone has to choose 3 or 4 of these things to start with, how can they do that and then scale forward with more granular information?
Yeah, we get this question all the time. What should we be measuring, right? And what does good look like? And often folks focus on one or two or three data points and really interpret them independently, right? But really, to quantify overall improvement, it's by balancing speed, cost, and quality, right? You can't let one undermine the other. We often use the analogy of a balloon, right? You squeeze here, it's going to blow up over here. You squeeze here, it blows up over here. And that really can't happen. What we're talking about is having a balanced pressure across all of those three levers to get consistent improvement across all of those domains. And we often talk about, I think the what do we call it? The project management triangle, right? Of speed, cost, and quality, you can only have two. But what we're really, because we're in this time of AI, really the question is now we can have all three, but you have to do it in a concerted way. So when we talk about metrics and how we measure and identify opportunities, we're looking for a constellation of KPIs or OKRs that mean improvement holistically. So the goal is alignment. So improvements in one area don't create hidden costs or quality risks elsewhere. That's what makes performance gains sustainable and meaningful. KPIs, no, like I said, KPIs and OKRs don't mean anything on their own, or they mean something, but really they need to be interpreted in constellations of metrics to indicate that holistic improvement. The metrics that most payers are collecting and measuring today are correct, right? Time, quality, cost, but by not looking at them together, it's often a trade-off depending on whichever part of the C-suite is yelling at you at that particular time. So by doing it holistically, we can really improve holistically rather than having trade-offs in one category or the other, which is really how we've been managing for the last decade.
That makes sense. That makes great sense. So, in our UM transformation business here at Availity, we're starting to see health plans prioritize reducing provider abrasion. And I'm assuming there's a key number of metrics they use to measure abrasion. But what we're interested in understanding is when a payer chooses to address provider friction, where do they start? And what are those first key areas? What are the measurements that they use as a baseline to understand the level of friction or abrasion? And then how do they plan to reduce it? And how can that impact provider experience?
Yeah, and addressing provider friction and abrasion is always something we talk about in UM. It's certainly become more and more important through regulations and commitments with AHIP and things like that. Um, but really, I think the way folks often go wrong here is they think of abrasion really as turnaround time, right? That's the way that we make providers happier is to get them a faster answer. Not wrong, speed still matters, but really the priority should be about reducing effort, not just improving turnaround time. Providers feel friction most acutely in the number of steps, handoffs, and exceptions that they have to manage. I think we all can resonate with that as anyone who's gone through a customer service or any process, right? It's not just how fast they get to the resolution, it's how many times we had to go back and forth and how many different steps I had to take to get to my resolution, right? So, addressing provider friction means simplifying those requirements, standardizing processes, minimizing rework and the back and forth that often happens in a prior auth or other discussion. The goal is to make the process predictable and intuitive, right? We want it to just seem obvious that this is what you would need to do for providers so that they can focus again on patient care, right? We want them treating members. We want them delivering quality care. We don't want them spending their time with administratively burdensome navigation through clunky systems. So it's all the back and forths that really cause friction and abrasion, not just I had to wait 3 days for or 5 days or 10 days for an answer. Yes, that matters. But effort reduction is what we really need to focus on in improving provider experience.
Excellent. Right. So then thinking about, the multiple portals and the different types of places a provider needs to go for a certain type of authorization, they may need to go to a delegated vendor and there's a portal for that. And then there's another they have to go to a different portal for a different type of service. So I can imagine the administrative burden and waste that is incurred in doing that. So, how do we move beyond that complexity, especially when, health plans need to be able to have delegated vendors? It's still going to be part of the equation. But how can we move beyond that multi portal complexity where the provider is having to figure out which place do I go? How can we meet them in the workflow and make their work less burdensome? Like you said, how do we reduce those number of steps and clicks and effort to get them the answers that they're looking for?
Yeah, meeting providers in their workflows is a great question and probably many different ways to do that. But, it's a great follow-up to it's really easy for me to say, yeah, we need to reduce friction by making it simpler, right? But your question is really how do we do that? So great. Exactly with the obvious question here. So really, meeting providers in their workflows means fitting into how they're already working today, right? We don't want them to have to pick up from what they're doing here and go over to an entirely different system or multiple different systems to try and get that thing that they need that's then going to get them back to their work that's right in front of them. So we want to fit into their work and not ask them to adapt to something new again. So as much as we can sort of fit into the current flow while finding opportunities to reduce that friction is the goal. So to be more specific, pairs can reduce friction in a number of ways. The big one that we all like to talk about is through an EHR integration, and that works for larger payers who have some of the bigger platforms that are already working on this. But that doesn't work for all types of payers, particularly non-traditional like behavioral health care, outside of sort of the main medical care, and even smaller practices that just don't have that sort of technology enablement. So, but other ways, standardizing data exchange, right? Having a single portal that then channels out to however many delegated vendors or pod structures you have internally or whatnot. The intelligent routing that happens behind a single portal, that's all our business on the payer side. That shouldn't bother the provider. They should have a single source of entry, right? So that standardized data exchange, consistent submission, and also I'll say status visibility really matters to our providers. Again, anybody who's ever ordered from Uber Eats or submitted a prior auth understands wanting to know where our order is. It's what helps us self-serve and also reduce frustration and just, I sent something, where is it now? So having that status visibility is a real, in addition, I mean, if you can't get to real-time determinations, letting your providers self-serve and know where their cases are really helps to reduce just frustration and confusion. Overall, the focus should be on fewer touch points, clearer requirements, and, like we said, real-time feedback where possible. When fits naturally into that existing clinical administrative workflow, provider experience fewer delays, fewer errors, and far less administrative burden and frustration with the payer that they're working with.
All right. Lydia, you have been so helpful and so insightful today. Thank you so much for your time and for joining us today. We appreciate your insights from the front lines, and we hope to see you again soon.